Hello, my name is Derek Enlander. I'm an internist in practice in Manhattan, New York. Today I'm going to speak about chronic fatigue syndrome, or as it's termed, CFS, or as it is also abbreviated, ME-CFS. ME-CFS stands for myalgic encephalomyelitis, chronic fatigue syndrome. Today I'm being interviewed by James Spero, a research assistant who is very knowledgeable about this disease and will pose some questions which I hopefully may be able to answer.
Thank you, Dr. Enlander. If we could, perhaps we could just start with an introduction, and you could describe for us, what you know about this disease in a general sense, and what some of your experiences have been.
This is not a new disease. This disease was originally described in 1955 by Melvin Ramsey in London. Melvin Ramsey worked as a clinician in the Royal Free Hospital in London, and he was confronted by a cohort of young physicians and nurses who suffered from a massive debilitating fatigue. He didn't actually understand what the cause of this disease was, and researched actually into why these young doctors and nurses were suffering. He believed that this was a sequel to a viral infection, and he in turn called this disease post-viral fatigue. The term was then changed to myalgic encephalomyelitis because Melvin Ramsey believed, and this was in the days before CAT scans, SPECT scans, PET scans, MRIs, he believed that this was a low-grade inflammation of the brain, muscle, and peripheral nerves. The disease actually created this massive debilitating fatigue, which he thought was a sequel to Coxsackie B virus.
Some years later, in 1970, I believe, there was a publication in the BMJ, the British Medical Journal. It was very controversial, which suggested that this had not been a physical manifestation of disease, but rather hysteria or something along those lines. And that it was later retracted, was it not?
Yes, well, this is not a new problem. We are actually today confronted by doctors, parents, school teachers, employers, who actually look at the patient and say, oh, you actually are not suffering from anything, you're imagining that you're suffering from a disease. This imaginary idea has prevailed, unfortunately, to the detriment of the patient.
I've heard it suggested that the researchers and the doctors in Great Britain who treat this disease view it as a condition where people do become ill, perhaps with a viral onset, but that the condition as we know it as chronic fatigue syndrome actually involves the patient then not getting better when most people would, and that involves controversial theories as to sickness behavior and the sick role.
Indeed. Dr. Wesley at St. George's Hospital in London, who was one of the co-authors of the Foucault criteria, which we will talk about a little later, has actually suggested that this disease might actually be a sequel to a previous viral onset. Indeed, actually, that can actually fit with a slight modification to our thinking. We believe that the viral onset of this disease can lead to an immune dysfunction, and immune dysfunction is the underpinning of this disease. This is not a psychiatric disease. This is a physical disease.
Which is an important distinction, and also there is sometimes some muddying of the waters rhetorically, because patients who understandably become defensive will say, no, I have a real disease, and the physicians will then say to them, but psychiatric disease is real too, and I have seen many times where they try to insist to a patient that there should be no stigma to mental illness, and there should not be, but that's problematic because we do see this as a physical disease. Can you tell me something about the prevalence in the United States? There are estimates.
We believe actually that there are between 800,000 and 1 million patients who suffer from this disease in the United States. The impact of 1 million patients suffering from this disease is colossal. We believe from the work of Leonard Jason and Nancy Klimas that the impact on the nation is between $1 and $9 billion, a massive number. This is actually due to the loss of product from these patients, the cost of medical care, and also the cost of supporting disabled patients under insurance.
What would you say has changed, if anything, in the recent past? Have we made any progress? What have we learned?
Well, progress has been very slow. In the past 10 years, it has been painfully slow. Painfully slow because we actually are still working to try and find the causal agent of this disease. Even with the research that has occurred in 2009 and 2010, we are still struggling to actually prove or disprove the existence of a causal agent. We'll talk about this in the next session under the XMRV virus research.
Can you tell me something about the different criteria that have been published over the years?
The original criteria, the Fukuda criteria that I mentioned, which had Dr. Wesley as one of the co-authors, was a sequel to the Holmes criteria, which was published in 1988. The Fukuda criteria were published in 1994 in the Annals of Internal Medicine. These were then updated into the Canadian consensus, which is basically the criteria that we like to use in the diagnosis of the disease.
The Canadian consensus criteria prominently features post-exertional malaise. And I would ask you if you would agree with the suggestion that fatigue and malaise are words that do not adequately convey what this condition is and how it's defined. I myself do not think that words can adequately express what this is, and fatigue is just the best or the only term that, but it's inadequate.
True. Because patients actually, when they express the term fatigue, most onlookers will say, yeah, well, everybody's fatigued, everybody's tired, so just get out of it, just shrug it off. This is not something you can shrug off. This is a massive, debilitating condition where the patient actually, in some cases, cannot get out of bed. The patient can be bedridden with this disease. It is not a simple tiredness. It is a massive debilitation.
But there have been some research studies in the past, and without getting into the XMRV just yet, that have been significant over the past several years.
Well, causal agent determination has been a problem ever since actually the Coxsackie-B suggestion that Melvin Ramsey came up with. Epstein-Barr virus has been actually suggested as a causal agent, as has CMV, cytomegalo-inclusion virus, HHV6, human herpes virus 6 and 7, have been actually suggested. Elaine de Freitas actually about 18 years ago came up with a notion that a retrovirus caused this disease. So retrovirus is not actually a new idea. Crooks wrote a book about the cause of the disease being Candida, and Nicholson in California has suggested that mycoplasma is the cause of the disease. The actual relationship of an etiological agent and the disease has yet to be established.
It seems to me that there are people who, when they discuss chronic fatigue syndrome, they are speaking of something that is heterogeneous, and myalgic encephalomyelitis, on the other hand, could be seen as more homogeneous. Would that be an accurate thought?
Maybe. However, there are patients actually who suffer from this disease and actually can, to some extent, do certain things, whilst there are other patients who are completely bedridden in a darkened room because light actually causes intense pain. There are patients actually who suffer from intense pain and loud noises. There are patients actually who are also actually subject to problems actually of peripheral neuritis. The slightest touch actually can be painful. So there are actually different manifestations of this disease.
Right. I don't think that one could suggest that there isn't a difference in symptom profiles. Let me ask you about recovery, and that's a difficult subject because there are people out there who claim cures, which is obviously problematic. I think most people would tend to view recovery as something that is extremely rare, if not next to impossible. How do you feel about that?
The disease is difficult to treat. It's difficult to treat for various reasons. One of the prime reasons of the difficulty is that we don't know the exact cause. If we actually assume that this is an infectious agent, which manifests itself by causing immune disturbance and also a disturbance in the peripheral vascular system or central vascular system, then we actually can try and treat these manifestations. We actually see that there are patients who have got actually POTS, which is orthostatic tachycardia, which is caused by postural change. When the patient changes position from lying to sitting to standing, they actually can manifest abnormal cerebrovascular problems. These actually are, we believe, caused by either a CNS, a central nervous system dysfunction to the vascular system, or by an immune reaction, which in turn creates an inflammatory cause to the myocardium in the heart. Paul Cheney has suggested actually that there is a manifestation in the heart caused by this disease or caused by an etiological agent of this disease. And we actually obviously cannot go and take a biopsy of the heart or of the brain to actually prove or disprove these facts.
But POTS, which is something that is diagnosed through a tilt table test, is that's a controversial test. To my understanding, they won't test people with chronic fatigue syndrome on a tilt table in Great Britain, and I believe that it's not widely used in this country either.
It was used actually mostly by the group in